Hello, everyone. Welcome to today's Taking Control of Your Diabetes CME program called Rapid Fire CGM Interpretation for Efficient and Effective Patient Care. I'm Dr. Steve Edelman, Professor of Medicine at the University of California, San Diego and the VA, and founder and director of Taking Control of Your Diabetes. I'll let my very good friend and colleague introduce himself.
Yeah, so thanks, Steve. So I'm Jeremy Pettus. I'm also an endocrinologist at the University of California, San Diego. Also work here at TCOID. I've known Steve for a zillion years. So happy to do this with you. And just giving kind of an overview of this presentation, the whole point is over the next hour, we're going to give some background on what CGM is, how to use it, but really it's to teach you how to rapidly interpret a CGM download so you can get information quickly and focus your visits with your patients on the things that really matter. And, kind of jumping ahead at the end of this, Steve's going to show me some cases, some CGM downloads that I've never seen before, and put me on the spot to see how well I can kind of pull out these key things without even knowing the patients.
Yeah, we don't expect him to get every case right on.
Well, I do.
But well said, Jeremy. The whole purpose of this exercise and this program is to help you rapidly interpret CGM downloads and make your visits efficient and effective. Your patients will be happy, you'll be happier, and it just saves time. Mm-hmm. So we do have one important disclosure which pertains to both of us. And we both have been living with type 1 diabetes since the age of 15, only about 24 years apart. And I also serve on the board of directors of Senseonics.
Yeah, and I think that's an important disclosure because, obviously we see patients, we do research, but we also, have our own personal experience with this. And between the two of us, we've worn pretty much every single device there is out there between, pumps, CGMs, et cetera. So we bring a little bit of our own, flavor to this as well.
Yeah, and you know what? I didn't want to put, conflict because it's not a conflict, mm-hmm. but it is a disclosure, and I think it's a good one, to be honest.
Yeah.
All right. Well, CGM has been the standard of care for type 1 diabetes for a long time. Jeremy and I are pretty much ahead of our time. I don't mind saying that. And we believe that in the near future, CGM will be the standard of care for all patients with type 2 from pre-diabetes all the way up to insulin therapy. And we now know any type 2 on basal insulin or more than one injection a day is eligible by Medicare and many insurance companies because there are many values that go beyond just making adjustments in pumps and insulin doses.
Can I just say that, yeah, and it wasn't always that way.
Right.
When CGM first kind of came out, I first got on mine in 2010, which wasn't that long ago. But then it was, it was really hard to get covered. People thought it was just kind of this fun little tool for people to have. And since then, all the data on improving blood sugars, reducing hypoglycemia, improving quality of life. So we're just using it more and more. And it's kind of like, duh. If you don't know anything about diabetes, you know that knowing your blood sugars is important. So these devices have become a cornerstone of diabetes therapy.
Yeah, and I encourage all of you watching, if you haven't worn one, you should, and get that experience. And when we first started 10 years ago, if you were type 2, I don't care how many shots of insulin you're on, you were not eligible. So it's just a matter of time. And I think you're right, Jeremy. The body of literature on benefits of CGM in type 1 and type 2 is very consistent. Mm-hmm. So I think it's just a done. It takes our medical societies time to make their changes, very slow. So CGM does allow for time and range and other important metrics, which we're going to be talking about in detail. CGM metrics allow for the most accurate way to evaluate long-term diabetes control and short-term. And there's a phrase called GMI. You're going to see it on the CGM downloads, and that's called glucose management indicator. We don't like that term, but basically it's a sensor-derived A1C versus the laboratory A1C. And it allows for efficient and focused way to evaluate and rapidly find out what the major problem is with your patients. And lastly, it is the backbone of a tremendous area, hybrid closed loop systems with automatic insulin delivery. And that without CGM, you couldn't have these systems.
Yeah. I just kind of add there that this is one kind of benefit of COVID. It's weird to even say that we were forced to do these virtual visits. And I think because of that, a lot of the clinics were forced to get better at getting this data remotely. So a lot of times now when I see a patient, especially if it's a remote visit, their downloads will be available the day before, certainly before the visit. So I always have that information. I can look at it, get an idea of what I want to talk about, what I think are the main things before I even see the person. Versus the old days, you go in, do they have their CGM? If they do, you go back out and plug it in, and maybe 15 minutes later you have it, that kind of stuff.
And the visit's over and they waste this much paper.
Yeah.
No, you're right. You're absolutely right.
So it's all about time and range. And, what is time and range? Well, we defined it as a blood sugar between 70 and 180. That was actually first established in 2019. We kind of have guidelines that you'll go over. 70 because we thought that was like the lowest end that, people should get to. Some people don't really have symptoms between 70 and 80, so we think that's still appropriate. And then up to 180, we will allow, after, meals for people to spike. Everybody has fluctuations in blood sugars, even people without diabetes. So notice it's not 100 and 110, and that's not our goal with people with diabetes. 70 and 180 is time and range because we know that's the place that people are safe. So our first priority for patients is getting a CGM. I mean, we should actually pause there. Get them a CGM.
I don't care who it is. Newly diagnosed type 1 should have it within 24 hours.
Yeah.
But if you see a type 1 without a CGM, they might have some misperceptions or a bad experience with the older models. But it's key.
And letting them know what, the options that are available now, how they've improved, all those things. Setting their alerts, which we'll have a whole section on, is very important. And then we'll have another section on how to respond to the trend arrows. It's not just a static number. It's going up, it's going down.
That's important.
And bolus calculations, how much insulin people are taking, are more than just carbohydrates. And again, these static glucose readings. You're going to need to take more insulin if your blood sugar is screaming up, really quickly. Less insulin if it's going down. So teaching patients how to use all this information.
And we're going to show you a study we did that is that brings out this point tremendously.
So in addition to getting your A1C below 7 or your time and range, 70 to 180, try to reduce the daily glucose fluctuations. We have some metrics here for what is a good kind of glucose fluctuation. A standard deviation less than 50 is great, or sometimes reports have the CV, less than 36 is the number that we've kind of landed on. Those are helpful to give you a ballpark of fluctuations. And then, of course, the insulin regimen that you're using should mimic what happens in normal physiology. So if you're on shots, you obviously need basal and bolus. And then if you're on pumps, how to teach patients how to use both those features.
Yeah, we used to say to people at the Taking Control of Your Diabetes conferences, multiple daily injections or a pump, the choice is yours. But now with hybrid closed loop, the HCL, it's a different ballgame.
Yeah.
And we're not going to talk too much about that. But it's an important issue, important advancements. Now, so this is the graph that shows the time and range goals. So you can see in green, the percent of time between 70 and 180 is called time and range. And the goal is 70% or higher. And I want to point out that that's 17.5 hours a day in range. And I think you pointed out last program we gave that that's a lot of time to allow outside of that range. And that's just life. And some patients can get in the 90s, not too many. But if anybody can get, close to 70, you're doing well. And they didn't just pick this number out of the hat, as you mentioned. A time and range of 70% will give someone an A1C of about 7.
Yeah. And we know that the more time in range, less complications. So this has been validated. And you're right. That means about a third of the time people can be out of range, which sometimes can be liberating. Hey, we want you to be in a safe place, but we're not asking you to be kind of perfect all the time.
Yeah, which is pretty much impossible. And then, of course, very important is time below range. Less than 4%. And it's important to point out, you can see it at the top of the slide. 1% represents 15 minutes. So 4% represents 1 hour. And so if you see a patient with 4% time below range, that means they're below 70 on average 1 hour a day for the length of that download. Now, one day they might be 2 hours, the next day they might be none, but I think it's an important metric. And this will all be brought out again when we show Jeremy these cases. And then time below range, less than 1%, that's below 55. And we try to keep that less than 1%. And I would say, I don't know about you, I focus on time in range and time below range. Yeah. And I don't really spend too much time above range.
Yeah, because those things kind of take care of themselves, the higher numbers, if you have good time and range. So as much time and range as possible, as low time below range as possible. Personally, I think 4% low is too much, an hour a day, but that's the recommendation currently.
Yeah, I mean, some people hover a little bit low and, in the 60s, they feel good that way, but we're not that happy with that. So on the left is the numbers and the goals I just showed you, but it's important to know, if you see patients that are elderly, a lot of comorbidities, you really want to avoid hypoglycemia. Time in range goal is above 50%, not 70, but you can see that they lowered the time below range, because when you're older and you have heart disease, having a bad low can be catastrophic. And then if you're type 1, they want you between 63 and 140.
This is pregnancy.
Yeah,
pregnancy and type 1.
Well, it says it right there.
Yeah, but you didn't, so I'm just
I'm sorry. No, I appreciate that. Yeah, and you might explain to me why you have to be more aggressive for pregnant and type 2. But anyway, they want, as you all know, when a type 1 gets pregnant, that hopefully they can get to a high-risk OB clinic that really can get their A1C down and their numbers in range without too much hypo. And then they still have the same less than 4% hypoglycemia. And then if you have gestational diabetes or you have type 2 and you're pregnant, it's the same 63 to 140, but now they want it over 90%. Probably because it's easier to get that range.
People can generally get there with less hypoglycemia. And yes, it's the same time below range of 4%, but the metrics are different, so it's less than 63. So people with pregnancy, they generally tolerate lower blood sugars. So we kind of redefine what hypoglycemia is in pregnancy.
Now, do you want to give just a quick word on time in tight range? That's kind of a new thing that's coming up in 2024.
Yeah, so again, our goals are time in range, 70 to 180. There's a lot of literature now coming out. Should we tighten that to time in tight range, which is between 70 and 140? And we're getting some data on what these new systems can do, but it's too early to kind of make this recommendation that should be our target. It might come with time if we can do it safely, but that's kind of to be determined.
Yeah, and maybe with better hybrid closed loop systems and more smarter algorithms and maybe different insulin preparations. But right now, it sets up people for failure.
I think so. It's it can really stress me out. I know if someone said I had to be 7140 all the time. I like 7180.
When is your commentary coming out in Diabetes Care?
It should be any day now. Maybe when this airs.
Jeremy wrote a nice commentary on that.
Yeah.
Okay, well.
All right, so my turn. How to review CGM overview and being methodical. And once you do this, honestly, 3 times, it just becomes like second nature and you can do it so quickly.
You're going to see how he reviews the cases that he's never seen before.
Yeah, so I'm actually slightly nervous about that. So review the CGM download together. This is important because, there's so many times that, doctors come in and I reviewed your chart results and this is what I think. Turn the screen around, show them what you're looking at, because the data that you're looking at is the same stuff that they see on their phones, on their apps, regardless of what system they're on. They're looking at this time and range metric. They're looking at their average blood sugars. So, for God's sakes, go over it with them.
It's the same verbiage, and you might be lucky enough to have technology where you have a big screen and patient sits next to you. Or if if you don't have that, you print it up.
Yeah.
And then you get out your Sharpie and you just mark the heck out of it.
So the first thing that these downloads will do, well, first of all, you should set up your clinic so all the downloads are the same. And in our clinic, we ask for the last 2 weeks, and we make sure that all the downloads are set to 7180 as their time in range. So you're looking at apples to apples.
That's important.
Yeah.
Yeah.
So when you have that actual patient, the first thing you can do is look at the average glucose. All the reports will give you that for that time period, for us 2 weeks. From there, it'll give you an estimated A1C, so you know overall what this person's glucose control is. You can look at their standard deviation, which I mentioned, but honestly, the next thing I do is I look average, I look at time in range, see where that's at, hopefully above 70, and then hypoglycemia to make sure that that's less than 4%, which is next.
Number 5, yeah. And, once you do this, you're going to see how fast you can say, okay, this is the biggest problem. Then we look at the 24-hour glucose profile. You'll see plenty of those. And I like to look at when they're the highest, when they're the lowest, and when is the variability the highest, because that tells you what areas to focus in on. And then you can review their alert settings. Now, most providers don't look at this. And I was in clinic this week with one of the fellows, and the patient's blood sugars were just high across the board. And I say, what were the high alert settings? And then they say, oh, I didn't even look at it.
And it's important to know that alert settings are completely independent from these time and range settings.
Right.
So a patient can set their alerts wherever they want, and you're still going to get the data download on time and range for 70 to 180. So sometimes people will think they have to set the alerts at 70 to 180 to get the downloads to match. It's not the case. You can, do those independently.
Yeah, and Jeremy knows I make a big deal of this, and I'll talk about it a little bit later.
This is like new thing, but I like it.
Yeah, you followed my advice a little bit too. And then they have individual days. Now, if you have a patient that's doing well, you don't have to do this. You're done. And you can talk about their favorite Peloton instructor, if someone's doing well. But sometimes it really is instructive to look at individual days to see for trends. And sometimes if you have time, I know time is tight these days, you might pick a day and say, what sort of happened this day? And you walk through it, and you can learn a lot by doing that. And it comes down if there's time.
I'd say a couple things. So some of these downloads will give you the patient's best day.
Right.
I actually like looking at that with them, especially if it was in recent history. So it was like, hey, yesterday was your best day. What did you do that day? And then it's usually not like a momentous thing. It's kind of like, oh, I just, ate a little less carbs, or I went for a walk or something.
Yes.
And sometimes that can trigger people. The other time I really use in individual days, if there's some event that they want to look at. Last Sunday I had a bad low, something like that. Okay, well, let me go back to that day and we can go through it together. Yeah.
It's very nice. And like I said, you may not need to do that depending on how the patient's doing, but it can be super instructive.
So, and then we want to talk about trend arrows. Now, this is more of a real-time feature. This isn't something you're going to be looking at necessarily in the downloads with patients, but it's so important. So we say it's extremely important for behavioral modification and dosing insulin, and the alerts and alarms, when set correctly, will help improve all these things.
Yeah, I always say that if you set your alerts and alarms correctly, you can improve your time and range 10%.
Yeah. So here's an example of a patient, and again, this isn't the quiz yet. This is one that I've actually seen. So here's a patient, but just to kind of go through this, what I would see is that their average blood sugar is 212. From there, it estimates that the A1C would be, 9%. We don't have their time and range and things like that here, but it would be very low. They essentially have zero hypos, so you don't have to be a rocket scientist to realize that this person's problem is they're high all the time.
And the variability is like this much.
Yeah. And you can see what's highlighted up here is that the low alert and the high alerts the low alert's okay at 80, but the high alert is 390. So this person is basically saying, like, don't bother me unless there's like a catastrophe. And that's not right. That's not really getting the most out of the device. I tell patients, set the alarm at a place that is going to be a call to action. That every time that alarm goes off, you should be doing something. If it's on the low side, you need to be eating carbs. If it's on the high side, taking insulin or something like that. But having it set at 390 is just, you're ignoring it essentially.
This defeats the purpose of wearing a CGM. And, there is a topic called alarm fatigue, and we'll talk about that as we go through. So you got to be smart and not give the patient a really tight range, and then it's going to go off all the time and drive them nuts, and then their partner wants to leave them.
So give us your spiel on your alerts and alarms.
Here it is. You have to spend time with your patients about lowering their upper limit below 180. One day it dawned on me, if we're trying to improve our time between 70 and 180, if I have it at 180, when it goes off, I'm already out of range. So why not lower it? And then you have to change your attitude. Instead of saying, damn it, I'm above 180, you say, yeah, I'm at 150. Let's look at the trend arrow and decide what to do. If it's straight across and you're going to go for a walk, you wouldn't do anything. But if it's diagonal up or straight up or two up, you're going to give yourself a little correction bolus. And that will improve your time and range. And once again, patients have to change their mindset because a lot of people hate the alerts and alarms. And my other suggestion, which is important, you can change the alert sound on some of these CGM devices. And the one that comes with the factory is pretty obnoxious. And that's the one patients equate with bad.
Yeah.
You're a bad diabetic. And there's a lot of cool sounds. And lowering the upper alert, I don't know if anybody's ever done this study. I've been quoting 10% because that's my anecdotal experience, but it's really true. It could make a significant improvement in time and range. And this is just...
Well, I think, if I can,
Yeah,
it's a
yeah,
great
of course.
suggestion. And I think it's important you say the first thing, spend time with your patients. So that last patient who had it set at 370, it's not like you'd say set it at 150 now. Like over time, you would get them kind of accustomed to it, bring it down. The default is usually 180, but I agree that's generally too high. So, let's try 170, let's try 160, let's try 150, and to kind of tighten it over time.
Yeah, and you let them take over. And I think getting them energized about this concept is important. And
I've heard him do it. When his alarm goes off, what do you say?
yes.
It kind of makes me mad that you get happy.
Do you know what? If you learn some of the techniques we're going to show you how to evaluate downloads, you could find that's the major problem.
Yeah.
And spend your limited time talking about that. And that might be the most important thing you can do. Here's just an example of what it looks like. Here's the upper limit set at 150 during the day, and then 10 o'clock at night to 7 a.m. we make it higher so that it doesn't bug them during sleeping. So everyone's individual.
Yeah, a couple things about this. So the other thing you have is the repeats. So here you have the high at 150, the high repeat at 30 minutes. For me, that's too often.
It is.
It takes a while for if you're going up for it to come back down. So the high repeat we usually have at 2 hours, something like that. The low repeat, usually 15 minutes or something, because you want that to be kind of reminded. But these sleep schedules are really nice because, again, it should be set at a point that you're actually going to do something. And if your alarm's going off at 150 at night and you're just not going to take insulin about it anyways, well, then don't have it wake you up until a point that you would actually, intervene.
Yeah, you'd much rather have lower during the day and not bug the patient at night. And you can reduce alarm fatigue. Yeah, I noticed that on this patient's download, 30 minutes for a repeat high is way too fast. Talk about alarm fatigue. That'll cause that because insulin just doesn't work that fast. So 2 hours is what I usually recommend, or 90 minutes, something like that. I'm not going to show you what each one sounds like, but here's just a list of the different sounds. And my favorite is the baby crying sound. But for the sake of time, we're going to...
Favorite meaning like the worst. I mean, it's just like awful. So, I mean, like the fact that that's even like an option, like, especially when you're low and then like you already feel like crap and you're angry and then you got this thing like literally like a baby cry, the most like obnoxious sound in the world. It gets your attention, but man, is it a negative connotation.
Eric, can you click on that and make it go off? We'll be able to hear it. Sure.
Yeah, I mean, who wants to hear that when you're high or low?
But it keeps going on and on and on. So anyway, I think it's just got to be a joke,
So the point there is that you pick something kind of nice, right?
Yeah.
So it's a more positive, okay.
Totally.
Yeah.
It really helps changing the mindset. I had mine on doorbell. It's very nice, but it sounds exactly like my doorbell. So then I would someone's at the door.
If you got a dog, they're barking and stuff like that, yeah. All right, so using trend arrows to dose insulin. So again, this is more kind of real time, but we did this study a while back now, and we asked 300 quote unquote successful CGM users. These are people that had an A1C less than 7 and low amounts of hypoglycemia, how they use their CGM. And we published this almost 10 years ago now. And they said the most useful thing to them was the real-time trend arrows and the high and low alerts. And the least helpful thing to them was actually the download. So it's kind of flipped between patients and providers. We look at these, retrospective downloads exclusively. They're dealing with this real-time information. Am I high? Am I low? What direction am I going, et cetera. So some kind of guidance on how to use these arrows is what we were looking for. So if you go to the next slide.
Well, I want to point out that you see the author of this famous study, and I was et al. On this one.
So we asked them this, which was, we actually showed them pictures, and we said, okay, if your blood sugar was 220 on the left side, and your blood sugars were flat, you haven't eaten in a while, you haven't taken any insulin in a while, and you just wanted to correct your blood sugar.
And you're not going to be exercising in the future. We gave them scenarios. Yeah.
Basically, you're as flat as you possibly could be at 220. How much would you take to bring your blood sugar down to, I think we said 120, 110.
120, like 120,
And on average, these people said 3 units, which is, sounds about right.
It's like a correction factor of 1 to 30, 1 to 33.
Which also does go to show you that the typical 1 to 50 for most people is way too conservative. Most people end up in the 30s somewhere.
And this is 300 patients. And this is the mean. Of course, there was variance around the mean, but you're right. I think, well, they always start off more conservative anyway with teaching.
So then we asked them the same thing on the other side and said, okay, same blood sugar, but now for whatever reason your blood sugar is like screaming up, double arrows up, how much insulin would you take? And they more than doubled the amount of insulin that they would take. Now we're not saying this is the absolute right amount, but the people that are using CGM well realize that you have to adjust your insulin dose based on what the curves are doing. Now this was back in the day before hybrid closed loop. This was people on, shots or kind of dumb pumps. So this is still advice that I would give to people on those systems. The hybrid closed loops are now still trying to correct for this.
Yeah.
But generally, you're still going to have to take a little bit more, a little bit less based on these trend arrows.
And then it reminds me to tell folks that, there are still people out there using finger stick devices.
Yeah.
So could you imagine you got a finger stick of 220 on the left and on the right, and look at the difference. It makes a huge difference having these trend arrows. And just to quickly show you, why don't you go through?
Yeah, so I mentioned the 3 units. There's a 6.8 unit, if they were double arrows up, and they took 1.5 of the double arrows down. So based on the, trend arrows with the same blood sugar, the amount of insulin people gave varied from 1.5 to 6.8 units. A huge range. And I think this was like one of the first studies that helped people open their eyes to, man, the glucose direction is hugely impactful. And we have to, start giving patients the tools and the ability and the comfort to adjust their insulin, not just based on the blood sugar, but the rate of change as well.
Most providers don't even discuss trend arrows.
Yeah.
So I'm glad you're watching. And don't forget, I was et al. On this famous paper. Just to show you, I made this graph. Happy to share it with you. If you email me at TCOID, you can see what the definition of those trend arrows are just below the arrows. So for example, diagonal up is changing 1 to 2 milligrams per deciliter per minute. And 2 arrows up is changing 3 or more. And then the suggestion for the patients are below. So let's just look at the diagonal up. So what we would do is we would tell the patient, you take your blood sugar, you add 50 points to it, and then you correct for that higher number. And then you even add 100 points with 2 arrows up. And we even think that's conservative. But we wanted to just let people start thinking, when your trend arrows are going up, you're going to need more insulin. And then a very conservative thing on the way down is, blood sugars if it's dropping, eventually it might level off. And then you wait for 3 cycles, like 15 minutes, 5, 5, 5. And if it stays level, if you correct for that number. And you can just, if you're really high, you just, reduce the amount of correction you would use if your trend arrows are going up.
Yeah, and the way that we came up with these numbers was thinking that insulin takes about 30 minutes to start working. So again, looking at that diagonal arrow up, if you're changing, let's say 2 milligrams per deciliter per minute, in 30 minutes, your blood sugar is going to be 60 milligrams per deciliter higher. So you're going to be correcting for that value. So you're looking into the future. So being more kind of proactive with your insulin dosing based on these trend arrows.
And that's how these algorithms for these hybrid closed loop systems work. Very sophisticated, but they do look at the blood sugar in the future. One hybrid closed loop system looks an hour in the future, and most of them do 30 minutes. Okay, we are ready for rapid fire CGM interpretation, and a good time to stop before Jeremy gets his ass whooped. Okay, now it's time for rapid fire CGM interpretation. Now, I went through a lot of effort to get the cases and set it up where he doesn't know a single thing about these cases because they're my patients. And so he's going to give an example of seeing a patient maybe for the first time, looking at their download, the first time they got a CGM, and he's going to do what we just suggested for all of you to do to review. So let's go. Case 1.
Okay, so that's it, huh? That's the ground rules. I don't know anything about this.
He doesn't know if they're type 1, type 2, what therapies they're on, nothing.
Okay. Well, let's go through it in the kind of systematic way that we outlined. So here you can see the average blood sugar is 237. From there, it calculates an A1C of 9. So again, you have an overall sense, A1C is 9, that this person is, poorly controlled. A1C is out of range. From there, we look at the time and range buckets. You can see the time and range is 16%. Our goal is above 70, so this person is wildly kind of out of range. But the good news is there's no lows, like the less than 1% low, 0% very low, so this person is just mostly high. And then you go down to this 24-hour period, which we didn't describe in kind of detail, but that dotted black line is the average blood sugar for that time of day. And the bars around the dotted line are the kind of the fluctuations around that time. So the bigger the bars, the more fluctuation, the lower the kind of less. And a little caveat here, that the Dexcom download, for whatever reason, can default to putting the time and range goal between 80 and 150 overnight. Do you see that?
Yeah.
So you would want to make sure that's actually set to 70 to 180 all day long, just for all of your downloads. So kind of summarizing this is a person who has an elevated A1C, poor time and range, no hypoglycemia, but is high all the time, all day long. And that's what you really get from this 24-hour period. Is it's not just bedtime, it's not just lunch, it's just kind of all day long.
And if you just had that 24-hour profile, you could say the same. You know their average is high. You know their time and range is low. You can see there's not having any lows. You didn't mention glycemic variability, the standard deviation.
Yeah, so that's something I was going to talk about. Is that the standard deviation isn't that bad. So when I see, I see mostly type 1s, but when I see a download like this, a couple things go through my mind. First, I always think, is this person afraid of hypoglycemia? That a lot of times you'll have patients almost kind of actively maintaining hyperglycemia because they're deathly afraid of lows. So, asking if they've had a bad low, in the past, if they've had a seizure, if they've had a glucagon, and just directly asking them, how do you feel about hypoglycemia? Are you afraid of lows? And sometimes that can be really helpful because all the carb adjustments and insulin sensitivity adjustments in the world won't, solve that problem if they're simply afraid of taking insulin. So that's, one thing that goes through my mind. The other is that this person, I don't know if they're type 1 or type 2.
Type 1.
Okay, type 1.
Give them a little clue.
This is likely somebody who's on shots, because if somebody's on a pump, the hybrid closed loop system would at some point likely be, bringing this person into range. So that's something maybe to talk to this patient about. So if they are on MDI, then it becomes, where are the issues? And because they're flat mostly overnight, this isn't, really a basal issue, that this person's basal is probably doing okay. They're just simply not taking enough with mealtime. They're not correcting. They're never bringing their blood sugars down into range. So I would talk a lot about, your basal's fine. We need to just get you more comfortable with taking higher doses of mealtime or correction insulin to bring you into range. Really dealing with the hypoglycemia part of that too.
Well, you did a nice job, buddy. I think you nailed it. Let me tell you the details of this case. Well, I put this build in here because emphasize what you just said, just high all day long. Mm-hmm. And, think about this. If this was down, we wouldn't be that unhappy.
Right.
Everything would be better. And so here's the summary. She's a 56-year-old businesswoman, super busy. She's on multiple daily injections. As you can see, her average glucose, GMI, standard deviation, time in range, time above range are all extremely high, very few lows. Looking at her 24-hour profile, it's fairly flat without major ups and downs. And she does work hard at watching what she eats. So you're right, there's a bolus issue here. She's above 180, 73% of the time. That means 18 hours a day she's out of range, just to bring that into context. And I looked at her alert settings, and you can see that, that she sets her upper alert at 200 and her repeat is off. So we'll talk about that. So I'll give a little more details about her. Okay, I've been following her for 12 years, and she's never had an A1C less than 9. I kind of feel guilty about that because I try, but nothing seems to happen. She just started some laser therapy for non-proliferative diabetic retinopathy. Her microalbumin just started to creep up after all these years, very minimal. She had a normal GFR and urine albumin to creatinine ratio, but upper normal. Very stubborn about making changes, super stubborn. And she's very bright, and she puts her job first. And interesting, she had gestational diabetes with four of her kids. But she doesn't have gestational diabetes. She has type 1 antibody proven. So, that's the issue. Any comment on where she set her alerts?
Yeah, I think that would be helpful. I think when I see that alert set that high and that profile, I'm just thinking this is somebody who's just generally apathetic about their diabetes. And like you've said, this has been going on for years. So you're wondering, well, how do you get through with to these people? And you can see these complications. And I think a lot of providers kind of gravitate towards that. Like, see, if you don't do this, you're going to get like these complications. We know that generally doesn't work. Yeah. So it's meeting people where they are. What are the barriers? Are there ways that she can, start, taking more insulin? I try to start with like literally one thing. Can we start with just dinner? Like whatever dose you're taking of insulin, it needs to be, amplified, whether that's a carb ratio or just a couple more units, trying to break off one thing at a time rather than we need to do all this stuff and bring you like, down to 7 overnight.
Yeah. It turns out
tough.
Yeah. This is tough. You've already hit on the major parts. And this person has their alarm on vibrate. So she's busy. She's an investor. So she's running around crazy busy. So here's some suggestions that I came up with and have tried. Lowering her upper alert to 150 and not just doing it, but talking to her about it just during the day. Turn on her repeat high at 90 minutes. Hers currently is off. And spend some time talking about the trend arrows, as we've mentioned multiple times already. And I think it's worthwhile trying to talk her into one of these hybrid closed loop systems. And you can see at the bottom, I said especially the iLet, which is a pump that requires very little input from the user.
Yeah. And we did, the original clinical trials with that system, and it was exactly this patient that did the best with the iLet. On MDI, A1C elevated. They're comfortable kind of letting go control of letting the system bring them into, range. And in general, people can get down around an A1C of 7 with not doing so much. So I kind of assume that pumps have been brought up to her probably multiple times. Yeah. But this is another good time to bring it up again now that there's a new system to talk about.
All right. We're spending way more time on the therapeutic interventions, but we still have 7 more cases to do. So make a long story short, she needs help.
Yeah.
And I referred her to Dr. Bill Polonsky or Susan Guzman because you're right. It's not a hypo fear to an extreme, but no one likes hypo, and she doesn't like it at work too. And discuss screening her 4 daughters for autoantibodies. Now that we have Tzield, which can delay the progression from stage 2 T1D to full-blown T1D. And even though she doesn't get low, it's always good to make sure they have a good, easy-to-use glucagon
security
kit.
Blanket,
Yeah. Okay, case 2.
All right, case 2. So this is different. All right, so I'll do rapid fire. Average blood sugar, AVE, I like that. ABEJ, is 173. It gives you an estimated A1C of 7.9, so not bad. This isn't the 9% we were dealing with last time. This is around 8. The CV is not too bad at all, 39%, meaning the fluctuations are reasonable. Time in range, 63%, right there, almost 70%. Time below range, 5%, so a little bit too much hypoglycemia. And then when I look at the 24 hours, this strikes me as somebody who probably is on a pump because you can see, or type 2, but basically you can see like in the morning, things are really kind of tightened up. So that's either a hybrid closed loop or probably a type 2. And then through the day, you get fluctuations. And with each meal, the blood sugars get a little bit higher. But the clear problem is dinner in this patient. So depending on the type 1 or type 2, that's kind of what I would focus exclusively on.
He is a type 2.
Yeah.
And he's on multiple daily injections. And I can point out that is probably the biggest perturbation of the 24-hour period. And that's something you can focus in on, which is what I did. And he also is getting low right there.
Okay.
So it's hard to see, but he is on, I believe, Lantus, and that's something that you can easily make an adjustment on. So let's just go through his case. He's 84 years old. He's a retired physician. I see him at the Veterans Hospital. He's had type 2 diabetes for 30 years, so he hasn't been diabetic 34 years. He's got chronic kidney disease. He's got stage 3B. He's on multiple daily injections. He's on glargine at night, 20 units, dapagliflozin and liraglutide. And the CGM metrics really just show a spike after dinner and low overnight. So,
and that's so important because, if you just saw that A1C, a lot of providers would say, okay, just some more Lantus, because that's what I can go up on. That's the last thing this guy needs. He needs less Lantus and something else to, address these nighttime spikes.
Yeah, and I put the tracing up on the subsequent slides so to remind people. So basically, I started rapid-acting insulin at dinner, titrated up slowly and really educated him on trend arrows. Also asked him to take his rapid-acting insulin, Humalog or Novolog or one of the fast-actings 20 to 30 minutes before eating. We know that's important. And the other thing that I think is kind of a more difficult thing to recognize is that I wanted to reduce his glargine by 10%, but I changed his dose to the morning because we do know that it kind of wears off the last 3 to 4 hours of the 24-hour cycle. And that way I wanted to reduce that 5% below range by doing those two strategies, lower the basal and change the time of the day. And my therapy isn't always exactly perfect. So this is what I did. And I set his low alert at 80 and to do a repeat in 15 minutes, as you suggested earlier. And
there's the glucagon again.
And maybe these new easy preparation kits. You're going to see this. The only thing you're not going to see on this slide that's repeated is check your family members for autoantibodies because he's not a type 1. And this just shows the CGM before and after. And you can see his metrics afterwards.
Wow. Yeah. So again, 155 average, his A1C came down to 7. So you dropped it by about a full percent. Time in range 77, and importantly, no lows.
That's it.
So
and he's 84 years old.
Yeah, that's great.
And so, I'm not going to show you the cases I really screwed up.
Yeah.
So you expect to be much better. Okay. Well, I just highlighted some of these. Yeah. No lows is key, and 77% range. Before he was below 70, like 65 or something.
Like that. Yeah.
Okay.
Good job. Case 2 summary. Okay.
Here it is. CGM data really showed the most important problem, which was high after dinner, a little low in the early morning. One shot of rapid-acting insulin solved the trick. Afrezza could have also helped out, but also the timing of insulin injections are important. And this is the key point that I mentioned earlier. Always consider over-basalinization, which is important, and what CGM can really help you pick up in your type 2 patients. And if you had just improved the dinner blood sugar with rapid-acting insulin, he for sure would have gotten low on that 20 units of Lantus.
I hate when I type basalinization, it has a little red squiggly under it because it's not a real word. But I'm like, it should be a real word. Anyway.
Well, it doesn't show it when you show the full screen. I hate that too. Okay, case 3, let's do it.
So here, I'm glad you picked a case like this. So this is somebody who has an average of 96, which we give him an A1C of 5.7. Time in range is not great at 65%, but interestingly, the reason that it's not higher is not because of too much hyperglycemia, it's because of too much hypoglycemia. So this person has a total of 16% of the day low, so it's like 4 hours a day they're hypoglycemic. And then you can see the 24-hour profile where these lows are happening essentially all the time, at night, after meals, after breakfast, after lunch. So this is somebody that's essentially low all the time.
Here's the tip. It's type 1 on a hybrid closed loop system.
Yeah. So this is like one of the most...
And she lives like this.
Yeah. This is one of the most difficult types of patients to treat, that they get it in their head, that, they have to have, perfect blood sugar control. I bet this patient has been praised over previous years and even brags about having an A1C of 5.6. But these are the patients I'm worried the most about because any one of these lows can be catastrophic. They can have a seizure. They can die. They get in their head to avoid long-term complications, but they seem to fail to recognize that the thing that's going to kill them is a car accident or a seizure or something like that, which they somehow just kind of come to terms with.
And they always say, I feel fine.
Yeah, I never had a bad low or whatever it is, but you don't have a bad low until you do.
And her husband is at wit's end.
Yeah, it's my case, man. So, these people take a lot of work, how to get them comfortable with, higher blood sugars, definitely getting them on the hybrid closed loop system. These patients are all about safety, getting them glucagon, getting medical alert bracelets, making sure people are following their blood sugars. But difficult patients to help.
Yeah, you nailed it, buddy. I'm glad I was your mentor. These arrows just show, I even missed an arrow at night. That's all the red. Yeah. And so she's having a ton of lows, not just a lot of lows. So basically, she's a 72-year-old who developed type 1 later in life when she was 40. So you can see that all of these metrics are excellent, but her time below range is, I'd say, shockingly low.
Yeah.
And just to give you were right, 4 hours. You're good at math. She's below 74 hours a day, but you missed the below 55, 90 minutes a day. And she says she plays golf. She says she feels fine. And here's her settings. the upper alert is set at 170, the low is 60. And I think for someone like her, that's way too low, but that's where she set it. And she has a history of several unconscious hypoglycemic reactions, paramedic visits, ER, hospital visits, and she's on a control IQ. So we can talk about her settings, but that's not the purpose of this program. And very stubborn, super stubborn. And so that what did I do? I talked her into raising her alert to 90 or 100, and she changed it to 80. And so that was the negotiations. She turned on her low, her repeat low every 15 minutes. She raised her, I wanted to raise her sensitivity factor, making her hybrid closed loop, give her less insulin for any particular calculation that the algorithm uses, and refer her to a clinical psychologist. That probably is the most important. She's a smart lady.
Yeah.
Very smart. She knows everything, and she's had doctors beat up on her for hypo. So I used reverse psychology. I was nice. And it takes time. Whoops. And I think that's it. So let's go to the next case.
Yeah. So you didn't have follow-up on her, because these are people that generally takes years to see kind of an improvement.
Yeah, I have follow-up.
So I would be surprised if all of a sudden she was like fixed, but these are, good interventions for sure.
Yeah, and I made sure she had a glucagon kit
there it
too. I've had multiple visits with her, and I'm making some headway.
Good.
Some headway. Okay, case 4.
Case 4. So this is a slightly different looking download.
Yeah.
And you get 2 decimal points, which is nice here.
You can see it's from the Eversense there.
Oh, we got a date of birth, so 2001. So this is a 3-year-old somebody, so probably type 1.
Yep.
You let that one in. So you can see the average blood sugar is 125, fantastic. The A1C would be 6.3. Glucose variability is actually very low. Time in range is 81.86%. So excellent time in range. But again, a little bit too many hypos, a total of 7%. So
that's basically that's 1 hour and 45 minutes a day. Okay.
I don't know if you have the 24-hour thing. Okay.
I do. It's right here.
All right. So here we were trying to look at where the problems are in terms of hypoglycemia. It looks like kind of in the morning, 7 to 8 a.m., depending on if this might be before the person eats. You have to kind of ask, is this before breakfast or whatever, and then kind of again at night. So
it's 6 p.m.
He does really kind of drop overnight. So if this is somebody on MDI, be worried about too much basal insulin. Again, if they're on a hybrid closed loop, I would look at some of the basal settings and the correction factor. But it seems like this is really kind of a precipitous drop overnight. So that'd be the first thing I'd want to do, is get rid of these early morning lows. And then you can tackle kind of these probably pre-dinner lows also. So probably too much basal one way or another.
Well, one little hint that you had no clue is that he does get up early and does exercise.
Okay.
Yeah. So, but you're going to focus on this, and you're going to focus on this.
Yeah.
So you nailed it. So I can give you. He's kind of an interesting kid. He's 22 years old. He's type 1 diabetes at the age of 7. He's on multiple daily injections. He works as a scuba diver instructor at Club Med.
And
he
get free tickets or something? No, for you.
Oh, for me. They only allow people under 40 at these places. They conduct 2 dives a day. He conducts early in the morning and in the afternoon. And when his low Eversense vibrates underwater, he knows he's low.
That is a cool feature of the Eversense. You get these on-body alerts that you don't necessarily need the iPhone or whatever for. So the Eversense for a diver is a good
underwater,
idea.
33 feet.
Yeah.
That's pretty good. And so basically, to cut to the chase, I reduced his basal dose by 5 to 10%. I also told him that he needs to reduce his insulin 2-3 hours before the dive, reduce the meal bolus by 20 to 30% calories and his insulin dose, because that'll be the insulin plus exercise, and swimming is intense. That'll help reduce the lows, and give appropriate pre-exercise snacks like peanut
Yeah,
butter
and I mean,
crackers.
especially something like diving where you just can't eat or get access to carbs. You can't come up quickly. So you're going to have to tolerate a little bit of hyperglycemia.
Yeah.
You want them to be 150, 180 to give a safe range. Like being that, like getting low 30 feet underwater sounds like a literal nightmare to me. So
Yeah, and if he was on a pump, of course you have to take it off. That's why he's not on a pump. But you're right. You'd rather be a little bit on the high side. And I don't think any exercise drops blood sugars more than swimming. And he's right. He's all the equipment.
yeah,
You swim?
I can't swim.
Okay.
Okay.
So educate his coworkers, recognizing hypo, give him a glucagon kit, and then talk about screening his first and second degree relatives for autoantibodies. Okay, case 5.
Case 5. All right, so this one looks a little bit more bread and butter. So average 162, A1C 7.2, right there. So this is, before going on, this is somebody, regardless, I'm going to be congratulating them about this. Yeah, they're not exactly where we want to be, but man, they're darn close. So this becomes right away, I know this is going to be a visit about fine-tuning things to help get this person like over the finish line. Or the time and range is 66%, again, right there at 70%. And, great that they really don't have that many lows. And I always say, it doesn't mean they don't have lows. They can have a bad low and then kind of recover, but it's not a constant, continuous problem.
Yep.
You look at the 24-hour download, this looks like a classic download of a type 1 that's on a hybrid closed loop pump. You see that they're kind of high on average midnight, 1, 2 a.m., but then the pump has time overnight to bring them in range. So between 6 and 9, you can see that standard deviation really shrink down. So they're waking up consistently with a good blood sugar. And then really just picking one thing to focus on, I would start with dinner. Because they're usually going high after dinner.
You always start with dinner.
Yeah, because
I noticed
because of this. It's usually the biggest meal. But then when people go high, they often are high all night. So if this person just started nailing their dinner bolus and brought that down, they would be just cruising overnight.
Yeah.
And their time and range might be 80% just with that one intervention. Then you could start working on probably breakfast. Is where the kind of things start going high. So this is a great example of you can focus on one thing and just say, man, you're killing it, but here's a way to be just like an all-star.
Yeah, that's excellent. One thing I'll point out, since you seem to forget the standard deviation, you don't mention that much.
Yeah,
Now, it's important to note that this 67 is above the goal of 50 standard deviation, but it's the average of the whole 24-hour period for the length of the download. But so you can see that in the early morning, as I can't remember what this patient's on, but the hybrid closed loop, you can see that standard deviation, those bars are narrow. So it's probably like 20 there, and he gets high after eating. So I'm pointing out that he's doing great there, and then goes up after lunch, after dinner, and I think whenever you see someone continue to go to bed above 180, 200, you got to talk about snacking. And I think, who doesn't snack at night?
Yeah.
So here's the summary. 28-year-old female, T1D since childhood. She struggles with insulin resistance. She's on a hybrid closed loop system. Good going, bud. It is that characteristic 24-hour profile. Reasonable control, but could do a little better. Hypo's not a problem. And her main issue are these spikes and variability after meals and late night snacking. So there's her profile on the upper right. And these are some of the things that I did. I discussed techniques to reduce postprandial high, and that's without getting into a whole hour seminar. Timing of insulin, Afrezza, reducing the carbs, and some post-meal exercise can all help. Whatever she can do. Give appropriate pre-meal snacks. Give appropriate
pre-snack bolus.
Bolus for snacks. Thank you. Adjust the insulin to carbohydrate ratio. She might need to make that more aggressive before meals. So instead of 1 to 10, it might be 1 unit for every 8 grams as an example. And suggest low carb snacking options.
You're right. And when I actually see this download, snacking is what I usually think of. And I tell people the human being usually small breakfast, medium lunch, big dinner, and then mindlessly eat between dinner and bedtime. And we kind of convince ourselves that those little snacks don't count. Oh, it's 3 crackers, it's 4 grapes, I don't need to take insulin for it. But it adds up, and then you go high and you're high all
No one
night.
Eats 4 grapes.
Yeah, exactly. That's the thing. You think you're going to eat, 1 or 2.
And you're watching TV.
Yeah. It's a big old bag of grapes, just popping grapes.
Well, our good friend Bill Polonsky, clinical psychologist, calls that the werewolf syndrome. Once the sun goes down, God forbid any foods out there. And we did a good video on that. Okay, so what did I do? Discuss screening relatives for autoantibodies in addition to the prior ones. Suggestions, make sure she has an unexpired, easy to use glucagon preparation. This is just a picture of my kitchen of low carb snacks.
Yeah, you can't see your rabbit. I think maybe in the background you can see Wilbur like behind the door back there.
Yeah, you're
Cute
right.
little white bunny. Anyways,
and he's not the snack. And then of course, egg beaters is your favorite.
Don't get me started.
Hard-boiled eggs are good too. This is a great study. It's an old study, but it's probably one of my favorites. And you want to take people through it?
Yeah, I'll just do this kind of quickly. Basically, what they did is type 1s, gave them the same amount of carbs, and had them either bolus 20 minutes before, which is the best curve, at the start of when they ate, which is the other one, and then the post meal. And you can see the same amount of insulin for the same amount of carbs. Just bolusing 20 minutes before you eat has a profound effect in avoiding that spike. And I also like to say that if you do it at the time that you eat versus 20 minutes after, it's like, it doesn't matter. So what I take from that is if you bolus right when you eat, you're already way too late. You're behind the 8 ball. You're never going to get it kind of quite right. And then ultimately everybody comes down to the right place.
It takes 6 hours.
It just takes a long time to get there.
Yeah.
But in order to avoid that hour to 2 hour spike, it's more about timing than the dose.
It's all about timing. Okay, now this study is also one of my favorite studies. It took a group of type 1s and on different day in different order, they gave them different meals, but all had the same exact carbohydrates. So I'm just going to focus on the top here, or the bottom first, low fat, low protein. And the top is high fat, high protein. And you can see the blood sugars went up to about the same peak, but they stayed high. And in the beginning of this talk, we talked about bolusing is not just based on carb counting. It turns out that protein and fat also raise your blood sugar, but slower.
Yeah. What I love about this is so it's all the same carb content. So what they did, it was a pizza with just the sauce. So that's, the crust is the carbs. And then they added the cheese and pepperoni and protein and things like that. So it's the same pizza and the same amount of carbs, but they added the fat and protein.
Were you a volunteer for that study?
I wasn't. I eat pizza frequently, so I wish I was. But the idea here is that even if you get your carb counting right, you have to account for the protein and fat, which is no real great formula for, just more insulin, more little touches.
And to keep an eye on your blood sugar. And that's why my upper alert is set at 150. So if it is going to creep up later on, I catch it early. Okay, case 6.
Case 6. All right, so this is kind of an interesting one. So high average 241, high estimated A1C 9.1, time in range not great at 29%. Again, thankfully no lows. Person's high a lot. And then you look at the time of day, this is different than the first case where it was high all the time. This is kind of interesting that blood sugars do okay between the hours of 3 and 9 a.m. and then everything goes to hell, kind of the rest of the day. So this is an interesting one. No matter what, this person's not getting enough insulin. So if they're on a pump, they're not, the basal rate's not high enough, the correction factor is not aggressive enough at night. They might be kind of trying to maintain high blood sugars, like I was saying before, bad problems with lows. Not bolusing, maybe not even at all for meals.
Just start with dinner, right?
Just start with dinner, yeah.
But Jeremy, you're doing awesome. I think the key here is what part are you going to focus on during the visit?
I'd focus on
expect
the
you
day.
to guess what they got. Yeah, that's it.
Yeah.
You say, this tells you they're doing great at night, but something happens, at that second arrow. So let me tell you about this patient. It's a 24-year-old woman. She's 4-year history of type 1. She wears an Omnipod pump that does not have automatic insulin delivery. So she wears what we call a dumb pump, and she has a Dexcom, CGM, markedly elevated average glucose, GMI, standard deviation, time above range, and only 29% time in range. So she really needs improvement. She does very well between 2:30 and 9:30 a.m. She sleeps in late, and every morning, this is part of the history, she goes to Starbucks, she's behind you in line, and she orders a matcha green tea latte. Now, she heard the word latte and tea. It's free. So it's 45 grams of carbs, rapidly absorbed carbohydrates, 320 calories. So basically, to cut to the chase, we lowered her upper limit to 180. We talked about that. We made her correction factor, her insulin sensitivity factor, more aggressive so that when she did go up, it was able to bring down her blood sugar and to try to make her own matcha drink at home using Splenda or stevia.
Yeah, people hear things like, Jamba Juice and they think it's good for you, or coffee is free. Man, you can get a lot of carbs in those things.
Yeah, we made her insulin, carbohydrate ratio more aggressive. And we talked about if she is going to drink anything, to take her insulin early, and talked about Afrezza. Afrezza would be good, rapid acting inhaled insulin, and to start with a pretty good dose. And of course, the same last two things to discuss autoantibodies with their first and second degree relatives and get a glucagon kit. And I put this on every case now because people have to start remembering that we need to start screening people. Okay.
This is the last one?
Yeah. So you get some information first.
Okay, geez.
75-year-old male with type 2 diabetes, CKD. He's on basal insulin. He's on DAPA. He's on finerenone. This is kind of a different type of clinical situation that CGM helps you diagnose. 93% time in range, but his physician was puzzled why his laboratory A1C was 4.9%. And he was worried that this guy was getting low at night. So he prescribed a CGM for him to wear, and this is what he got. So what's the
I think that
what's the
cut
diagnosis?
to the chase is that this person's blood sugar control is excellent. A1C estimated at 6.8. Time in range, 93%, no lows. So this is a great example of the A1C just being wrong. This person has CKD, probably some anemia with it, some reasons that the A1C can be inaccurate. And we always say, what's a better estimate of your average blood sugar than your actual average blood sugar? So I'm glad this person, got a CGM to figure this out.
And it showed he wasn't low at night and that the laboratory A1C is just not accurate. This is just a slide I got from Earl Hirsch of all the different things that can make the laboratory A1C inaccurate. CKD, anemia is the most common. Now we got to squeeze in this last case because it's the most fun.
Okay, so to cut to the chase here,
Just cut to the chase.
Nighttime control is the problem. So either this person is just going crazy werewolf and just eating pizza and all things at night, or this is some kind of nighttime worker. A bartender who works at a club, or a shift or Uber driver, somebody that's working at night and sleeping during the day.
You messed up because you messed me up. I had a pop quiz here.
Oh.
Whoops, shoot. Is this guy an emergency room physician, a law enforcement officer, bartender, or stripper at a nightclub?
Well, since I think it's you, this is probably D then, right?
So he was an ER physician.
Okay.
And just to summarize, he's 40
works
years
at night.
old.
Yeah, okay.
The night shift, yeah. And he super erratic scheduling at work. He's on a hybrid closed loop system.
Which is working well in the day, which is when he's sleeping, yeah.
Which is like most people in reverse.
Just flipped, yeah.
Yeah, and he's very hard on himself because he's a doctor. Everyone at UCSD looks at his records when he's not looking, and why is he screwing up? And basically, the interventions are pretty simple. Try to get on the day shift. Review his alerts and alarms to make sure he catches his highs going and his lows ahead of time, and consider lowering his insulin sensitivity factor or his correction factor overnight. So, and discuss screening his relatives.
And glucagon, yeah.
This is my last slide, and it just, to repeat what we talked about at the very beginning, this is my handwriting.
This is a real piece of paper of Steve's, and this is not like something he did for this talk. He does this with every patient. Big old black Sharpie. At least it's not red, so it's not like they're screwing up.
Yeah, and that way I give this to them. I put their goals down, and you can see I try to get them to go to bed between 140 and 180, and to bolus for snacks. That's basically the end of the program. So the summary is: be methodical when reviewing CGM download. Pay attention to the alerts and alarms. Spend time educating your patients on how to respond to the trend arrows. It'll pay off big time. And focus on the most important abnormality: elevated glucose values, hypoglycemia, excessive variability when you look at the downloads, and then focus your visit on the biggest abnormality and review your CGM download with your patients. Do you have anything to say?
No, this has been fun. Thanks. I'm glad it was fun to go through those kind of blind, and I think I nailed it. You know, probably even better than you did as the physician seeing them. So, you know. Anyway.
You know what? I was going to give you a compliment. What I was going to say was, you did a damn good job.
Thanks, buddy.
And, you know, you got into the area of trying to guess what they're on, but that wasn't the purpose. You just want to look at it and say, we need to focus on this.
Yeah.
Okay, everybody, enjoy and have fun in clinic with your patients.